Welcome, everyone, to the Tapia Panel Best Practices for Validating Machine Learning in Medicine, with panelists Megan O'Brien, Riyad Bin Rafiq, and Sarah Moudy, with myself, Mark Albert, as the panel moderator. Optimal decision-making is one of the ideals in managed healthcare, and with the massive, rich data sets available on interventions and health outcomes, there is a great deal of untapped potential. Data-driven precision healthcare can revolutionize this 1/6 of the economy that impacts people's lives directly. However, one of the fundamental limits in the application of AI to healthcare is that aspiring computer scientists are comparatively poor at testing their models, and the clinicians who can benefit from automated and computer-assisted decision-making that AI can provide do not often have the tools, vocabulary, and especially time to vet the systems that computer scientists create. We will first introduce our panelists, followed by a warm-up introduction of how critical AI is becoming in healthcare, underscoring the need for proper modeling strategies. Then our panelists will address a series of questions about the nature of AI validation in healthcare. Our three panelists represent a cross-section of interests and experience in applying AI in medical contexts. Dr. Moudi studies biomechanics of injuries in clinical settings, while Mr. Rafiq focuses on the AI tools necessary to build gesture and activity recognition in wearable devices. Dr. O'Brien bridges between these extremes in her role as a research scientist in the Rehabilitation Technologies and Outcomes Lab in the Center for Bionic Medicine at the Shirley Ryan Ability Lab, where devices are validated through a combination of scientists, engineers, and clinicians working directly with patients. Additionally, all three panelists are relatively early in their careers, giving a glimpse of opportunities with a few years of training. Dr. Moudi is a postdoctoral researcher in the UNT Health Science Center, transitioning to more computational methods in her work. Conversely, Mr. Rafiq is a computer scientist transitioning into applying his skills towards clinical applications, while Dr. O'Brien has been in this intersection for years as a research scientist at the top-rated rehabilitation hospital in the country, the Shirley Ryan Ability Lab. To put that into context, the Ability Lab has been the #1 rehabilitation hospital, according to the US News and World Report, every year for the past 29 years. And so we welcome her expertise. Now we will have the panelists introduce themselves and tell us about their experiences and plans for applying AI in healthcare.
Hello, my name is Megan O'Brien. I'm a research scientist at the Shirley Ryan Ability Lab, which is a clinical rehabilitation hospital in Chicago. I'm also a research assistant professor at Northwestern University. So much of my work focuses on whether wearable technology like smartphones or small body-worn sensors can help us measure different health outcomes in clinical populations. So I've worked with data from patients with stroke and Parkinson's disease, spinal cord injury, and even data from infants. Sometimes the work I do means using commercial devices with pre-trained algorithms to get measures of step count or balance or sleep. But most of the time, I work with raw data. I collect raw data and then build custom algorithms for these populations to design models that are specific to that patient group, or hopefully they can more sensitively capture how movement or health changes over time. So it may be kind of cliche at this point, but my experience has been that poor models almost always stem from poor data. So really your classic garbage in, garbage out kind of mantra. This can mean not enough data, or messy data, or data that just doesn't represent the true clinical use cases. For us, we sometimes have to go back to the drawing board, revise our protocol, and obtain a new or even larger data set. And other times we may need to simplify our model or be realistic about its limitations in more of a real-world setting.
Hello everyone, thanks for joining the panel. My name is Riyad Bin Rafiq. I am a PhD student at University of North Texas. Currently, I am working in the Biomedical AI Lab at University of North Texas as a graduate research assistant. In my undergrad, I found out that artificial intelligence would make our life much more easier and comfortable in the near future. So I took interest in learning artificial intelligence and how to implement it for better healthcare. As hearing impaired people are deprived of usual communication around themselves, I worked on a deep learning sign language recognition model for better communication. At present time, my research interest is to develop a more general recognition model for patients with limited ability to communicate verbally. Thanks, everyone.
Hello, everyone. Thank you for attending the session today. My name is Sarah Moudy, and I am a postdoctoral research associate at the University of North Texas in the Health Science Center. I work specifically in the Human Movement Performance Lab, where my research centers on determining injury risk factors in individuals with lower limb pathologies, such as amputation or osteoarthritis or chronic pain. And I do this by examining movement deviations when performing daily activities such as walking or exercise tasks. I am currently expanding my research into using wearable sensors to monitor gait deviations outside of a lab and implementing machine learning techniques that could aid physicians in diagnosis and determining treatment.
Okay, before we get to the questions, let's take a few moments to understand why AI is so critical to healthcare and where it's going. The potential benefit of preventing a disease or finding the most effective treatment are incalculable, but even the more tangible benefits and growth in this area are astounding. Accenture predicts the savings possible in healthcare due to AI will reach 150 billion in 7 years. Where does that come from? For example, robot-assisted surgeries are expected to save $40 billion. But there are also massive savings through better administrative systems. Virtual nursing and administrative workflow assistance may not sound as high-tech and cool as robosurgeries, but will lead to just about as much savings, almost 40 billion. But let's also consider something like medicine dosage errors. Expected savings there due to AI is around $16 billion. But let's put the potential to avoid medical errors into perspective another way. 40,000 people in the US die per year from car wrecks. But in a review in 2016 out of Johns Hopkins, there came a more troubling number stating that 250,000 hospitalized patients died from medical errors each year. Now, that number is debatable, but if it's anywhere near 6 times more deaths due to medical errors than to car accidents, that seems like a place ripe for AI to literally save lives. And the investment in healthcare AI is ridiculous now. According to Report Linker, what was a few $1 billion in healthcare AI will be tens of billions in 5 years. That's an expected 50% annual growth rate, a number I've seen from more than one source. There's a wave of investment coming, but it will only be utilized with the right models, with the right data, and appropriately reaching out to clinicians to make sure the technology matches the needs of the patients. So please, let's listen to what our panelists have to say in this expanding industry. All right, on to the first question. How has the use of AI changed the way problems are approached in your area of healthcare?
Now that higher computation is more available and inexpensive compared to 10 years ago, we can integrate AI at the root level of personalized diagnosis. For example, we can easily track our steps just using a mobile phone. In the future, we will be able to track our distinct values, blood sugar, etc. with wearable devices. Integrating all of that surely makes our life a lot more easier and comfortable, and also cost effective. By cost effective, I meant that we can minimize the number of visits to doctors and diagnosis centers, even to a therapist. Moreover, with the technology advancement, we can analyze millions of data and fit models and generate models that can be used biomarkers such as neurodegenerative disorder, tumor detection, cancer cell detection, or can be used sequencing genomes, and many more. From creating new medicine to giving personalized therapy, AI can be utilized in every sector of healthcare while quality of data is here.
So one of the key areas of research in clinical and sports biomechanics is the use of prediction algorithms to detect injury risk or the onset and progression of disease. So the ability to gather quick data on a person's movement and determine their risk of injury or disease is crucial for proactive healthcare. On the flip side, AI could also be used to determine when an individual can or should return to normal activity following an injury or surgery without placing them at a risk of re-injury or slowing that recovery. It's also worth noting that in biomechanics, we commonly estimate what is occurring in the body rather than using invasive techniques such as placing an electrode needle in a joint. In order to get accurate estimates, we typically use high-cost equipment, which requires a methodological expertise in order to gather lots of data and gather that data accurately. So there's some new research that has been using just a few wearable sensors, which are very low cost and inexpensive, and they're non-invasive. And then you combine that with neural networks, and these can accurately predict what those invasive measures might be. And so this is a low cost, and it's probably easier on the individual as an alternative to the invasive and high cost equipment.
As you might guess, AI is a very hot topic in lots of different areas of healthcare. In my area of clinical rehabilitation, continuous data from wearable devices or smartphone apps could completely transform the way that we study disease progression and recovery in our patients, and maybe even how we would intervene to improve their health. Especially with these devices becoming smaller, less intrusive, having a longer battery life, becoming less expensive, we really have access to more data and more kinds of data than ever before. Whereas our current methods of detecting and monitoring disease often rely on a clinician's judgment based on what they can see, sensors and wearables can give us high-resolution, objective, continuous data about a patient's movement, their mobility, their muscle activity, the way their heart is beating, or even analytics about their sweat. However, these potential benefits are really dependent on AI and clever signal processing to turn all of that data into something that's clinically meaningful and interpretable by the medical professionals. So it may do very little good to put, say, an accelerometer on a patient's wrist and say, well, there you go, that's what their movement looks like. Instead, you need robust and validated algorithms to make meaning out of that data, like computing step counts to measure physical therapy dosage, or determine how they're sleeping at night, or flagging any instances of tremor in their hand that may be indicative of Parkinson's disease, or detecting if someone falls down and needs medical attention. So that's where you can really change the whole continuum of care, and clinicians can make more informed decisions about how to structure their treatment to maximize the potential impact of it, or maybe determine how medication is affecting their patient's symptoms out in the real world, day to day on a 24-hour basis, or maybe even help them transition safely back to the community after their hospital stay.
All right, next question. Please give an example of how an AI approach seemed to underperform your expectations and how you believe better AI validation methods or clinical collaboration could have improved that experience.
As a biomechanist starting to work with AI techniques, the biggest concern that I have is that the predicted outcome is actually true. We need to have good confidence that the model is reliable and accurate, especially when the model outcome is a factor in diagnoses and treatment options. And a way that this can be improved is from having a combination of proper validation techniques and an understanding from a clinical collaboration of what the input data is and the clinical outcomes.
Currently, the situation in AI seems promising on a research paper or theoretically, but when a model is executed in the front line, it is most likely it will be failed. One of the reasons is the availability of quality of data and lack of proper data infrastructure to optimally train algorithms, fit models, and test models. A recommended way to assess the need for more realistic dataset is the need for true collaboration where data scientists and computer scientists work directly with healthcare providers to use relevant collected data. The most importantly failure of AI in healthcare sector is lack of proper validation. One reason for that is that models and systems are becoming more complex, requiring not only medical professionals and statisticians, but also engineers and computer scientists. Proper scientific model validation may not be emphasized and is often not present in relevant computing journals. However, trained models may function on subpopulations that differ from the group for which the model was designed. In medical applications, such uses are best validated for the particular population. In the cases in which the model demonstrates poor performance, it may be possible to improve the performance by tailoring the model to the specific subpopulation. For example, when creating an activity recognition system for older individuals or people with movement disorders, unique patterns of movement may be misidentified. To again use activity recognition system as an illustration, it is well known that activity recognition systems which are designed using data in the clinic often perform poorly when used outside the clinic. One reason for this is that the types of movements experienced when instructed in the clinic differ significantly from the natural movements at home. For example, instructing a person to walk in the clinic leads to a very stereotyped pattern of walking that will be fairly similar across individuals. Whereas someone naturally walking at home would have a different gait, including more irregular intervals of movements, changes in direction, and irregular cadence. To know how a recognition system would work at home, it is important to also consider at home collected data for a proper assessment. In general, having data which matches the context in which the dataset will be applied enables higher accuracy, particularly in scenarios where data is difficult to acquire.
A basic example of how AI can underperform for something that's of common interest to the rehabilitation community is using off-the-shelf devices to obtain something like step count for our patients in the hospital. So these devices often don't work well for our purposes because they are predominantly trained using data from healthy individuals, or at least people without the specific kinds of walking impairments that we see here, like people with stroke or amputees or spinal cord injury, who all can walk very differently. For our patients, we typically build custom algorithms using training data specific to that population, working closely with clinical collaborators for their input about different health characteristics of these patients. So that really helps us understand what data to collect. It also helps us understand the limitations of our models, which can happen as impairments or behaviors change over time from person to person. So as someone is recovering from a stroke, or they start using a walker, or they get a new prosthetic leg, we continually have to evaluate, is this algorithm going to work for this person? And that's what makes ongoing validation and clinical collaboration so crucial to guide AI development. As a data scientist, I might not be aware of certain things that are totally obvious to a clinician who has so much more experience and expertise with certain pathologies.
All right, next question. What specific skills would be beneficial to students pursuing your career path? Remind us of what that path is and how you would advise students interested in computing to prepare themselves for such a career.
We are living on the edge of drastic changes in the way we live our life because of AI. Now the healthcare sector needs AI professionals along with clinicians and practitioners in medicine. To pursue such a career, students should know data analysis to get valuable insights from data, as data is generated and stored more than ever. To manipulate the data, one should know a programming language. In this case, Python is much more preferred. As everyone talks about ML models applied to medicine, detailed machine learning and deep learning knowledge and their frameworks such as TensorFlow or PyTorch must be known. In my opinion, communication is another very important skill to contribute to this particular field, because a great communication skill can help AI practitioners to collaborate with clinicians and patients and understand the patient outcomes more appropriately. I wish good luck to new aspirants who want to contribute and work this sector. Thank you, everyone.
My current path is toward becoming an independent research scientist with my own laboratory, using computational methods to measure different kinds of health outcomes in different kinds of patient populations. So for myself and the other people I work with, there have been a lot of different paths that have kind of led us here. I came from mechanical engineering with graduate work in biomechanics, motor control, signal processing, and I first started getting into machine learning when I was a postdoc. Others who I work with have maybe come from other areas of engineering, like biomedical engineering or electrical engineering, computer science, data science, and others still have come from kinesiology, physiology, more that type of background. So we all have had blind spots, I think, going in. And for some, it's been on the computational side of things, whether it's learning how to program or about machine learning or how to design a neural network. And for others, it's been more about the healthcare aspects and clinical science and how to work with patients. So I think the best scientists in this area have a mix of both of those things. You certainly need programming skills. For example, experience coding in Python or MATLAB or R, all of which have nice support for data wrangling, processing, machine learning, but they're certainly not the only languages you could use. There's also a lot of good textbooks, courses, online resources out there to learn these different processes for machine learning implementation. But even if you're an expert data scientist, I think it's also really important to understand the clinical context of the data that you're working with.
All right, next question. One of the skills often missing from traditional analytics course sequences is emphasizing the ability to work with unstructured data. For example, data preparation, data wrangling. Can you provide an example of unstructured or unclean data in your line of work, how you address it, and why you think that's important?
Unstructured and messy data is pretty part and parcel when you're working with human data. There are many cases in AI when you're working with open source data or data that someone else collected. I'm in a fortunate position of designing studies from the ground up. So in some sense, we have a lot of control over the nature of the data that we're collecting. And by that I mean we choose what kind of data we collect, whether it's placing a sensor in a certain location on the body, what kind of tasks or patients we would use in the training data, and all of that is designed according to known research questions or use cases. Of course, in another sense, we have very little control over the data because human data is just messy and almost never goes according to plan. So after you've carefully designed your study with a known question, once things are happening in the real world, there's a lot more unknowns that you never could have planned for. So I guess our main difficulties with data wrangling and cleaning and those things tend to be missing data and what I'm going to call naturalistic data. So first of all, you might have missing data because for us, the battery on a sensor goes dead or the smartphone goes dead. A patient couldn't complete a task because of physical limitations, so we just had to skip it altogether, or they didn't want to wear a device on a certain day. I'd recommend defining sort of thresholds and expectations for how much and what types of data are required for your model. So if you kind of know in the ballpark, I'm going to need this much data, then if you have more than that data, sometimes you can exclude a subset of your data for certain analyses if it's incomplete, and often that's the simplest solution. But of course, it's a shame to lose that data. If you just exclude it, there might be a lot of other rich and useful things in there for the algorithm. There are certain algorithms that are able to handle missing values, so you wouldn't need to exclude it, but rather you could replace it with a nan value, say. Other times you can avoid data loss altogether by replacing missing data with, say, the mean value of the remaining data or the median or something else. There are also ways to use regression models or neural nets to kind of infer the missing values, kind of determine what those missing values should be, and then replace them with an actual number. But for those last two things where you're kind of replacing missing data with numbers or categories, use those techniques very carefully because you're effectively making up data, and you should really inspect that replaced data carefully to make sure it makes sense in the larger context of that person's data and their data set.
I would say that all biomechanics data is unstructured, in which about 80% of the time spent on any research project is processing, preparing, and analyzing data. The other 20% is about actually developing the project, collecting the data, and writing the results. So we spend the bulk of our time working with data because it is unstructured. So the data output is the same, and it's output the same each time for whatever piece of equipment or software you're using. But that output structure differs between different software programs, such as when you're using different motion capture systems, or if you were trying to utilize multiple pieces of equipment and therefore their software, and all of that data needs to be combined. For example, it's very common in biomechanics to collect motion data using motion capture software, and then combine this data with force plate data. Some of these data can all be collected in the same software program, but other times you have to combine the data after. Currently, I work with data in which you have to combine after you collect the data. And so we have to combine the data first before then inputting that data into a third software program to calculate certain gate features. Over the course of the last year, we have spent a lot of time in our lab creating code that will automatically restructure our data sets and combine data sets from multiple different programs into the same format. And this ensures that the data is in the same format to allow us to parse the data more readily in order to answer our research questions.
All right, next question. Deep learning neural networks and ensemble methods are state-of-the-art in many prediction problems, but the decision-making process can be challenging to explain. What problems does this present in your work or in clinical application, and how do you address these problems?
A constant question by biomechanists is, what are those driving mechanisms for injury or disease? This means that we want and need to know why a decision was made by the neural network. For example, if a prediction was made that a person is at risk for knee osteoarthritis, I would need to know what patterns in their gait were the driving factors for the neural network to say, yes, this person is at risk. Once I know these patterns, then we can start to develop a treatment option that would best reduce the risk for knee osteoarthritis. I'm not sure if there's any best way to address the problem of understanding that decision-making process, but one way that I can talk about is how we're currently addressing this problem, and that is by using clustering techniques prior to inputting the data into a prediction algorithm. So before we even get to trying to predict whether a new set of data this person might be at risk for injury, we first need to just examine what is driving the differences between somebody with knee osteoarthritis and somebody without. And we do that using clustering techniques to kind of parse out those driving mechanisms. Then once we can understand these mechanisms and we have a new set of data and we put that through a prediction, then we can make certain assumptions about what might be driving those decision-making processes. And then hopefully then we can create a treatment option by using the clustering results and the prediction results in conjunction with each other. hopefully in the near future, we can determine possibly some better ways to address this issue in the future.
All right, that concludes our panel today. We hope you found it interesting and useful. And a special thank you to Dr. O'Brien, Mr. Rafiq, and Dr. Moudi for your time. Good day, everyone.